Okay, let's jump right into this explainer, diving into an incredibly fascinating clinical pharmacy case that honestly reads exactly like a high-stakes medical detective story. Today, we're basically stepping into the shoes of a clinical pharmacist to decode a really complex patient profile, hunting down those hidden threats that could so easily slip through the cracks on a super busy hospital ward. To start us off, we really have to ask ourselves, how easy is it for a fatal blind spot to slip past multiple layers of review during a complex hospital admission? When a patient has multiple overlapping conditions, the sheer volume of data can completely obscure the most critical gaps. And as we're going to see, treating the numbers without understanding the underlying mechanics, well, that can lead us right into a trap. So let's look at our baseline, and man, it sets a very high-stakes stage. We're looking at a 38-year-old postpartum patient. She's 11 days post-expulsion, but she also has severe nephrotic syndrome. I mean, her albumin level is down to 20, which is dangerously low. Plus, she's dealing with a resolving acute kidney injury, leaving her with an estimated glomerular filtration rate, her eGFR, hovering right around 20. This combo of massive fluid shifts and severely impaired kidney function, it requires absolute precision. Section 1. The low-hanging fruit, the critical VTE gap. Let's move right to our first major discovery. This right here brilliantly illustrates our first crisis. Think about it. We have a patient who is literally a ticking time bomb for a blood clot. She's postpartum, she's highly nephrotic, meaning she's actually peeing out the antithrombin proteins that prevent clotting, and she has reduced mobility. Yet despite all that, there is zero pharmacologic blood clot prophylaxis active on her chart. Absolutely nothing. That untreated indication has to be fixed instantly. Our pharmacist immediately flags this glaring missing therapy. But here's the catch. Because her kidney function is so low, standard dosing is actually dangerous. So the recommendation needs to be highly specific. We either go with renal-safe unfractionated heparin at 5,000 units or a strictly renal-adjusted enoxaparin dose of 30 milligrams daily. Section 2. Plot twist 1. The electrolyte mystery. Okay, so we've averted the clot risk, but the plot definitely thickens when we check her daily lab results. We run into this totally perplexing electrolyte drain. Both her potassium and her magnesium are dropping dangerously low, and they are falling in exact parallel. Potassium is at 3.20, magnesium at 0.70. Now, in a patient with advanced kidney disease, you'd usually expect these to build up, right? Not get wasted. This is a massive red flag for life-threatening cardiac arrhythmias. Something in her system is actively bleeding these electrolytes out. The initial clinical notes point the finger directly at a loop diuretic. The chart literally says reduce furosemide 20 milligrams, which suggests that just stepping down this diuretic is going to fix the leak. Seems like a straightforward, perfectly logical next step, doesn't it? But here is an incredible plot twist. When we actually check the live medication administration record, the MAR, we realize furosemide is already completely gone. It had been discontinued prior. That clinical note telling us to reduce it, just a ghost note. If our pharmacist hadn't verified the live orders, we'd be trying to solve a puzzle with totally wrong pieces. So scratch the furosemide. The true culprit finally comes into focus. Hydrochlorothiazide, or HCTZ, at 25 milligrams daily. Here's the physiological reality check. Thiazide diuretics are completely ineffective at clearing volume when the eGFR is down around 20. It's providing absolutely zero diuretic benefit for her. Its only effect right now is acting like a sieve, bleeding out her potassium and magnesium. It has to be stopped immediately. Section 3. The red flag renal dosing danger. While fixing that critical electrolyte leak, our pharmacist detective keeps scanning the active orders and uncovers another urgent hidden threat just buried in the list. It's a major system error, a duplicate order trail for a blood pressure drug called moxidine. The current overlapping orders total 0.4 milligrams, but the absolute maximum safe threshold for someone with severe renal impairment is 0.3. This patient is at serious risk for toxic drug accumulation, which could trigger severe hypotension, sedation, and a dangerously slow heart rate. The urgent fix here is to clean up this duplicate trail and consolidate the dose down to a safe 0.2 milligrams once daily. And notice the crucial clinical pearl, we do not abruptly stop the medication entirely. Doing that could trigger severe rebound hypertension. We have to adjust it safely within those strict renal limits. Section 4. Plot twist 2. Cracking the pulse pressure. So, just when the medication list finally seems tidy, a fresh vital sign from the nursing staff throws the entire blood pressure strategy right back into chaos. A new reading comes in at 150/74. A systolic of 150 seems unacceptably high, especially for a renal patient, right? The immediate reflex for a lot of clinicians would be to just add another vasodilator to smash that top number down. But let's pause. Is a standard vasodilator actually a fatal trap in this specific scenario? To answer that, we have to look past the top-line numbers and calculate the pulse pressure. That's the numerical difference between the systolic and the diastolic. Here, 150 minus 74 gives us a massive, dangerously wide gap of 76 millimeters of mercury. Normal is around 40, by the way. We are dealing with isolated systolic dominant hypertension. Let's break down exactly how this builds, because this is where physiological mechanics absolutely trump simple guidelines. Step 1, she's nephrotic, highly edematous, and because we correctly stopped that useless HCTZ, she has no active diuretic. She is severely volume overloaded. Step 2, her chronic kidney disease has caused her aorta to physically stiffen up. Step 3, when you force massive fluid volume through a stiff, unyielding pipe, the systolic pressure spikes, but the diastolic pressure actually drops. That is the true underlying cause of this wide gap. Understanding those mechanics completely flips our strategy. Adding a blunt vasodilator wouldn't fix the volume overload, and it wouldn't fix the arterial stiffness. Instead, look at this master plan. We stop the ineffective HCTZ, we strictly avoid new vasodilators, we carefully titrate losartan, which actually helps modify the disease for her kidneys, and, crucially, we restart a loop diuretic like furosemide, which actually works at her current kidney function, to offload all that massive volume. The big overarching rule here, and the exact reason we avoid new vasodilators, is that her low diastolic pressure of 74 is a strict guardrail. If we use a vasodilator to force that 150 down, we're going to drag the 74 down into the 50s along with it. If we do that, we risk starving her heart and her fragile kidneys of essential blood flow. That hyperperfusion is exactly what we have to avoid. Section 5. Resolution, the pharmacist's master plan. Pulling all these clues together gives us some really profound takeaways. Honestly, this whole case is a masterclass in reading between the lines of a chart. It shows exactly why clinical pharmacists are so vital. They don't just blindly read numbers, they interpret the actual physiological mechanics and intercept systemic errors in real time. Always, always trust the live MAR over an outdated note. Remember that thiazide diuretics are basically useless in severe kidney impairment. Match your blood pressure strategy to the mechanics of pulse pressure, not just the top number, and never ignore a missing prophylaxis order. I really want to emphasize this incredible quote from the clinical notes one more time. A low diastolic is a guardrail. It just perfectly encapsulates the mindset we need. Every single vital sign, every single lab value tells a mechanical story. If you just chase a high number without respecting the guardrails, you can literally drive the patient right off a cliff. So, I'll leave you with this provocative thought to take back to your own words, your clinics, or your studies. Take a really close look at the patient profiles in front of you. What outdated notes, duplicated orders, or completely misunderstood vital signs might be hiding critical dangers in your practice right now? Keep asking those hard questions, keep cross-referencing, and embrace your inner medical detective. Thanks so much for joining me on this explainer. Keep learning and stay curious.